Hi, sorry I can't be there in person, but we're going to go ahead and do a video conference on this. Hopefully I will be able to visit India again in the near future. Today what I'd like to do is go over breast ultrasound, why strain and shearwave elastography is important for your practice. The objectives are to review the principles of elastography, discuss how elastography can be used to characterize breast masses, and in doing so, increase the number of positive breast biopsies and decrease the number of biopsies of negative lesions. Learn how to perform both strain and shearwave elastography, and to describe how to incorporate elastography into your clinical practice. Palpation has been used for thousands of years to evaluate the human body for pathology. So ancient Greeks and Egyptians knew if there was a hard mass in a breast, it was going to be a bad situation. And elastography is really the imaging equivalent of a clinical palpation. So instead of using our finger to decide if something is stiff or soft, we're going to use the transducer. So this is the imaging equivalent of doing a physical exam. So we now have three ultrasound modes. B mode, that looks at acoustical impedance and gives us anatomy. Doppler, that looks at motion and gives us vascular flow. Elastography, that gives us mechanical properties and gives us tissue stiffness. So why would we want to use elastography? So elastography contrast for cancerous and non-cancerous breast lesions is between 1,000 to 5,000% as diagnosed by Kupsik in 1998 in in vitro study. So there is a huge difference between cancers and non-cancers in terms of elastography. Unfortunately, for other organs, it's not as great. So we would expect that elastography would perform best in breast imaging. There are two types of elastography: strain, which the stiffness is calculated based on the displacement of tissue with a compressive force. It's qualitative, so we don't know exactly how stiff something is, but we know how stiff it is compared to other things in the field of view. And shearwave elastography, where we use an ultrasound push pulse, or ARFI, acoustical radial force impulse, is applied to the tissue, and conventional ultrasound is used to measure the speed of the shear waves that are generated. And from the speed of those shear waves through the tissue, the strain modulus can be calculated. So we actually calculate the exact degree of stiffness of the lesion. So just a little bit of physics. If we look at strain, what we do is we have LO as our tissue, and we apply a stress. And we'll talk about what that stress is for the mind ray system as we go through the talk. And then the object changes shape. And the strain is how much it changes shape. So the more it changes shape, the softer it is. The less it changes shape, the stiffer it is. And this is my typical physics slide, an almond in a bowl of Jell-O. And we're going to apply a force here with the spoon. And what we do is, as we apply the force, you'll notice that the almond doesn't change shape. It's stiff. The Jell-O, particularly near the top where the spoon is, changes shape a lot, and it's soft. And that's all that we're doing. We're looking at the frame-to-frame differences as that force is applied and released, and to see how the tissues change. The more they change, the softer they are. The less they change, the stiffer they are. So let's take 5 voxels on the left, and when we apply our force in the middle, you'll notice that they each change shape differently. The one in the middle changes the least, it's the stiffest, so we're going to color code it black. The one in the bottom changes the most, so I'm going to color code that white. So we've got our two ends of the spectrum, and then what we do is we use a scale that will be a gray scale that covers the other 3 as they change differently. So the darker the shade of gray, the stiffer it is. The lighter the shade of gray, the softer it is. And that's all that strain is. It's quite simple. But again, you have to remember that we're looking at the relative stiffness. So just because something is the stiffest in that image, it doesn't mean it's a cancer. And you can use different colors. I like to use black and white, where black is stiff and white is soft. I find that I can do measurements better, and I can see artifacts a lot better. And the technique to get optimal images is different for each manufacturer. Some require little or no compression, like the mind ray system, while others require manual compression and release. So in some systems, you may have seen that you have to move the transducer up and down a millimeter or two to apply that force. So in the Mindray system, you don't do that. That'll only give noise because the system is so sensitive. Just the patient's breathing and heartbeat are enough to generate the accurate amount of stress. And again, I like to do black is stiff and white is soft. So fat is always going to be white in a breast. Cancers are going to be black if it's the stiffest lesion. If a cancer is not present, usually the glandular tissue will show up as black. And there are many, many color maps. But again, I recommend you not use them because I think we can do a better job when we use grayscale imaging. In terms of the technique, the elasticity images are obtained with the probe and lesion perpendicular to gravity. So if the lesion is medial in the breast, we usually keep the patient supine. If it's lateral, we usually roll them a little decubitus so that the lesion, as they're breathing, is in the same plane as the probe. And again, for the Mindray system, you basically do nothing except hold the probe gently on the breast. So again, we really are interested in in-plane motion. So as the patient's breathing, we want that lesion to go up and down in the imaging plane. We don't want it to go in and out of the plane because then it'll look like it changes shape, not because of the pressure applied, but because we're imaging a different part of the lesion. Some technique tips: always keep the field of view large to include fat, normal breast tissue in the lesion, and you may want to add the pectoralis muscle. That way, fat is always going to be the softest, and if there's not a cancer, usually the pectoralis muscle will be the stiffest. So you've now set your gain, if you will, of the color scale so that things will be relatively uniform between cases. If the lesion is cancer, it will be very stiff. It'll be black if we're using the gray scale, and the other tissues will be very light gray because usually the cancers are so much stiffer than all the other tissue, they show up quite nicely. And as you're doing these exams, even if you have bad technique, you usually can be able to get good images on the cancers because of that. It's the benign lesions that you struggle sometimes to get good images. You should always try to compare the lesion stiffness to other tissues. As a general rule, something that's as stiff as the glandular tissue is probably benign. If something is stiffer than glandular tissue, it's most likely going to be malignant. And again, you can look at the B-mode image that's occurring as you're doing this to see the amount of displacement. And that really should be something on the order of 0.1%, so almost less than a millimeter. All of elastography, particularly in superficial organs, is very dependent on what I call precompression. Some people call it preload. And basically, if you apply pressure with the transducer, then you are increasing the stiffness of the lesion and the breast altogether. And when you do this, you're going to get inaccurate results. For Shearwave, the numbers are going to go up. So if you use a cutoff value, you may have false positives. In strain, it usually means that you're going to get just noise. And we did a study some time ago that we looked at different tissues and measured their shear wave speeds for different tissues from the breast. And that total compression is about how much I compressed, where I looked at how much I was compressing the breast. So at 50%, I took the breast and I made it half the size by pressing on the transducer. And that's probably about the area that we would do a mammogram at. But you'll notice that the cancers are very stiff to begin with, and even if you apply pressure, they become stiffer. The benign lesions actually increase in stiffness much more than the cancers do, and you'll notice if we get to the part about 35 or 40% compression, the stiffness of even fat is the same as a cancer. So we always want to do our imaging down in that 0 to 5% range so that you're applying very little pressure. And we'll talk about how to do that right now. So we did a study, and what I found was to train our sonographers how to do this and be uniform and everybody do the same. We pick an object in the image. So it can be a rib, it can be a Cooper's ligament, it can be a calcification. And when we do our B-mode imaging, we usually apply some pressure because we flatten out the Cooper's ligaments and we eliminate a lot of a reverberation artifact, a refractive artifact, So it's a good idea to have some compression when we're doing B mode. But then when we go to elastography, we want to release that pressure. So what we do is we look at the rib, and the image on the right shows that the rib is at 3 centimeters in depth. Then I start lifting up the probe, and as I lift up the probe, I can see the rib fall down now to 4 centimeters. If I would lift the probe up any more, I would lose contact. So again, it's to look at something and just lift the probe up, watch something in the far field, and when you get it to be as far down in the far field as you can, that's where you should do your elastography, both strain and shear wave. And this is an example of, again, the red arrow is pointing to a rib. And you'll notice in the top images, it's about 12 millimeters. It's about 16 millimeters in the middle one, and about almost 2 centimeters in the bottom one. And there's a little epidermoid cyst that you don't see very well. But if you look, when I applied a lot of compression, we don't see anything. When we get to the mild compression, you'll begin to see in the upper left of the box a little black round thing. And what often happens at this level is that as the patient breathes in, they expand their lungs and compress it more. We get noise. And as they exhale, we compress less and we see the lesion. So on the video clip, the lesion appears nice and goes away. Nice and goes away. And in the bottom, where you see the nice black round circle corresponding to that epidermoid cyst, on that video, it's all uniform, and that's because we're applying minimal compression. This is, and again, when we look at shear wave, we look at these displacement curves. So each of these waves, if you will, is watching the shear wave go through. And the numbers in that right-hand corner, the distance from the RF pulse. So that green one in the upper left is the one that is going to see the wave first. It's going to be the highest. As we get farther away, we get attenuation. And what we do is we plot the peak versus the distance, and that gives us our shear wave speed. What you'll notice as I start to compress, all of the waveforms move to the left. And the reason is the shear wave is going faster. It's easier for you to understand maybe if we look at a case. Here we've got a simple cyst on the left image. And as I start to apply pressure, and again, look at that rib at the bottom, you'll notice that the rib is getting closer and closer to the transducer. And as I do this, you'll notice that I can turn that simple cyst into beautiful cancer by just adding pressure. So it's very important that you understand pre-compression, and everyone in your lab is doing the same amount of pressure so you get consistent results. Going to strain elastography, you know, there is something very unique about breast that rarely happens in other organs, is that malignant lesions appear larger in strain elastography and actually also in shear wave, and benign lesions appear smaller. And I use the elastography to B mode ratio to characterize a lesion. So if you look at the image on the left, that lesion is 6 millimeters on B mode, and it becomes almost 8 millimeters on elastography. So it has a ratio of greater than 1 and is an invasive ductal cancer. The image on the right measures 10 millimeters on B mode and only 8 millimeters on elastography. So it's less than 1, and it was a benign fibroadenoma. So in addition to that E to B distance ratio, a second method is using the Elasticity Score, where we have a scale of 1 to 5. A score of 1, the lesion is entirely soft. A score of 2, we have hard and soft components. 3, the lesion is hard and smaller than on B mode. 4, the lesion is stiff and the same size as B mode. And 5, the lesion is stiff and larger than it is on B mode. We're going to ignore that image on the right about cystic because you may notice that on some machines, but that does not occur on the Mindray system. We're going to talk about that shortly. They have a different artifact. The third method of evaluating the strain is to do the strain ratio. So what we can do is, here I'm using a color map. Always be certain that you include the color map on your images, because some vendors like blue is hard and some red is hard. Some will let you pick whichever you want. So it's important that you know which scale you're using. So here you have a lesion. It's obviously bigger. That E to B ratio is greater than 1. It's bigger and stiff, so it would have a score of 5 on the 5-point color scale. And here what we did is on A, we put a circle over the lesion, and on B, we put a circle on fat. And the system will calculate how much stiffer the lesion is than fat. And we always use fat as the reference material. Ideally, we would like to have it at the same distance from the transducer in case we are applying pre-compression. That'll help normalize that, but in this case, we can't. And I usually use a ratio about 4.5 for the Mindray system. Each vendor calculates strain a little bit differently, so that cutoff value may be different. And again, in this case, the ratio is 8.6. Again, all three methods of using this demonstrate that this is highly suggestive of being a malignancy, and it was an invasive ductal cancer. Using that E to B ratio, we presented our results initially, I think it was in 2006 at RSNA, and then we did a multi-center trial, international trial. Here, N is the number of patients, B is benign on pathology, M is malignant on pathology, B less than 1, the number of lesions where the lesion was less than 1 on the E to B ratio, M equal to or greater than 1, the lesion was greater on the E to B ratio. If we look at the malignant lesions, you'll notice that 5 of the 6 centers had 100% sensitivity. One center only had 97% sensitivity. And when we look at those 3 lesions, they were invasive ductal cancers and DCIS. And we think that they probably were measured incorrectly on B-mode imaging, which led to the false reading. So one of the key features, if you use this, is you need to be able to measure accurately on both the B-mode image as well as the strain image. If we look at the specificity, there's quite a wide range from 67% to 95%. And we did this study before we truly understood pre-compression. And I think that's why there was so much variability with the specificity. And again, I told you, when you do these, if you have a malignant lesion, you can be have very poor technique and will get good results. It's the benign lesions that if you don't have good technique, you'll suffer with image quality. Here is just, I pulled some papers out of the literature that shows the different techniques. And if we look at the specificity, you know, they're in the high 80s and then low 90%. Sensitivities, again, in the 90s up to 100%. So we recently published a meta-analysis where we looked at the 3 different methods in the literature. And what we found was that using the E to B distance ratio had the highest sensitivity and the highest specificity. The LRN is negative likelihood ratio with 0.03 for the E to B distance ratio. And what that means is that if we have a pretest probability of 50%, so all BI-RADS for B lesions and lower, we can downgrade them to a 2% probability. So we would be able to downgrade 4 B lesions to a BI-RADS 3. On the other 2 methods, we could only downgrade 4 A lesions to a BI-RADS 3. Here are the curves, and I want to point out, and I'm going to see if I can get my little pointer to work here. You'll notice that in the ROC curve of the E to B distance ratio, we had one person who had pretty poor results compared to everyone else. And this person used color. And I will tell you, when I take an image in black and white, and then I go through the color maps, I actually measure distances differently. Our eye perceives things much differently with those colors. And I think that this is the reason why he had poor results, was he was using a color map. And you'll notice that for the strain ratio as well as the 5-point color scale, much more scatter in the results. Let's move on to Shearwave elastography. Instead of applying a stress, that compression and release, but for us it's just breathing, one applies a push pulse or RF pulse. which create waves in the tissue. And this is just like dropping a stone in a pond. The stone is the RF pulse, and the ripples in the pond are the shear waves. And if we measure the speed of those shear waves that are occurring perpendicular to the push pulse, it is proportional to the stiffness of the tissue. The faster the shear wave speed, the stiffer the tissue. So I think what's another important thing to remember is when we're looking at breast lesions, they are very heterogeneous, the cancers in stiffness. So we have to use 2D shear wave where we get that large color map that plots out the stiffness values over that whole region. Because if we're using point shear wave, we don't have that color map and we don't know where we should take our measurement. So it's very important to use 2D shear wave when we're doing breast. The advantage to shear wave elastography, we calculate the absolute value corresponding to the stiffness. We'll talk about the problems with it as we go along through the talk. People say it's less operator dependent, but for the Mindray system, you can just push the buttons between strain and shear wave and not do anything to the transducer and get good results. So the learning curve is exactly the same. An example on B mode, hypoechoic lesion, spiculated mass, hyperechoic rim, some internal and peripheral blood flow. And here you can see on elastography that the lesion is much larger, and I didn't measure, but it's obvious that the cancer becomes much larger. And again, you'll notice that the cancer is very black and the background tissue is almost white. And here you can see a little chart that shows you how much you're compressing, and you kind of want to stay where this line is. And again, just doing nothing will get you good results. So here we are in shear wave. Same lesion. You'll notice that if we go by the color scale, the cancer for the most part is very soft centrally, but we have this high rim of stiffness in that extra area that we noticed on the strain. So remember how big this lesion was on strain? You'll notice that that area that's extra on the strain turns out to be very stiff. And this is not an uncommon situation where the cancer itself appears very soft, and this is just an artifact, but we use the surrounding tissue. So it's important when you're looking to find the highest area that you only not look at the lesion, but look at the surrounding ring around it for about 3 millimeters. Another example, a hypoechoic lesion, some through transmission. And here what you'll see is in the Mindray system, we don't get that blue, green, red BGR artifact. We get what I call a bullseye artifact, where we have a white inner dot, outer black rim, and a white distal dot. And we've looked at this in great detail. This is 100% sensitive and 100% specific for a benign, simple, or complicated cyst. Because this artifact occurs because all the material inside this cyst is moving. So that's what generates this artifact. If there is an inclusion, a solid component that's not moving in this cyst, we'll see a defect within that cyst. If we look at this on shear wave, you'll notice that it's low in stiffness. And you know, we can't distinguish a fibroadenoma from a complicated cyst on shear wave because they both have about the same stiffness values. So we have to use elastography strain to be able to do that. And the Bullseye artifact is exquisite in being able to do that. And we talked about why that cancer was soft in the center. In reality, that center was extremely hard. And some people have called these blue cancers or soft cancers. And in our experience, almost half the cancers may have that black or soft center. And some of them will have that ring, but occasionally some will only be very low. And here is an example of this. This is the same lesion. On every strain system that I used, the E to B ratio is greater than 1, and it was a cancer. On every shear wave system, it was blue without a rim and would have been interpreted as a benign lesion. So this is not a function of the vendor. This is a function of the histology of cancers. They are just so stiff that shear waves do not penetrate them, and in some cases, and will give you a false negative result. We looked at this in great detail, and we published this paper where here again, the cancer is blue, very soft, and we have the ring around it. And I showed you those displacement curves before where we have that nice family of curves. You'll notice when we look at the displacement curves within the cancer, the blue area, all we get is noise. And the system interprets this as being very soft. And if we look in this peritumoral area where we have the high stiffness values, you can see we have curves. They're a little noisy, but we can still calculate stiffness values. So we came up with the idea of using a quality map. So green is go, yellow is caution, and I'm sorry, green is go, yellow is caution, red is stop. So what this does is it looks at the quality of the shear waves. Are they high enough? Do they make sense? Do we get a nice straight line to calculate the shear wave speed? And then it color codes this. And you'll notice here is a blue cancer, and it's all red. So this is telling you don't believe this result. And again, we published this in a paper, and we showed that if we add the quality measure, and if we have a solid lesion and the quality measure is bad, we can get almost the same results as we do with strain. If we don't use the quality map, we get actually much worse results. So let's talk about the difference between strain and shear wave. So for strain, we can image at any depth. As long as you can get a good B-mode image, because we're just looking at the frame-to-frame differences, we can get a good strain image. On shear wave imaging, the problem is that the RF pulse gets attenuated, particularly in dense breast tissue, and if you've got a large breast, you may not have enough energy left to generate adequate shear waves. Precompression affects both. And in our hands, strain, is it a cancer? We do much better because we have the problem of the blue cancers on shear wave. Specificity, is it benign? We do much better on shear wave because we don't have any artifacts with benign lesions. But on strain, it's very hard to get good strain images sometimes because the lesion just blends in with the background. And obviously, shear wave is very quantitative and strain is not. And then assist characterization, that Bullseye Artifact we find to be extremely helpful clinically and eliminate a large number of biopsies using that. Where on shear wave imaging, if you have a truly simple cyst with no echoes, since we're using B mode to track the shear waves and there's no echoes, we can't measure a shear wave speed. It won't color code. If it's a complicated cyst that has some debris, then we will be able to calculate the shear wave speed, and it again will appear very similar to a fibroadenoma. This is from the WFM guidelines that were published in 2015. We are in the process of updating these. I'm hoping by early next year we'll have updated guidelines. But this table shows you the different methods and what we recommended for cutoff values. So the top three are actually all the same. They're the 5-point color scale. They're just showing you that blue is stiff, black is stiff, red is stiff. And again, the two right ones, if you have a system that does the Bullseye Artifact, and then the one far right is if you have the blue, green, red artifact, what they will look like. If we look at the E to B distance ratio, less than 1, we gave it as corresponding to a BI-RADS 2. If they were equal to this 1, we gave that a 4. If it was greater than 1, we gave it a 5. If we looked at strain ratios, and again, each vendor is different, and we didn't really parse that out, but in general, any strain ratio on every paper less than 2.8 was benign, and every strain ratio greater than 4.5 was a malignant. So we gave those a 2 and a 5 respectively, and then we kind of cheated and put the middle as a 3-4, because again, it's going to depend on which vendor you have. If we look at shear wave speeds, a VS of less than 2.6 or 20 kilopascals was negative in every study, and a velocity of 5.2 meters per second or 80 kilopascals was positive in every study, so we gave that a 5. And then for a 3, we went between 2.6 and 4.5, which is 20 to 60 kilopascals. And from 60 to 80 kilopascals, or 4.5 to 5.2, we gave that a 4. These values may change a little bit on the new guidelines. We're discussing that now, and there's a lot more research that's coming out that I think will be very helpful for us to improve our interpretation. So let's talk about the Resonance 7. Again, we're going to use the very light touch. Again, lift the transducer until you just have a little contact. You're going to hold that transducer still. Position the patient so as they're breathing, the lesion moves up and down in the imaging plane. And I'll try to do that in front of you here. So if this hand is the transducer and this is the lesion, we want the lesion to be moving up and down like this in the plane. We don't want it doing this. So again, sometimes you have to move the patient, particularly if the lesion is lateral. You may have to oblique them a little bit to get them to do that correctly. You can save a short cine clip and then find the best image to do your measurements. And you can perform this on both the 14, the 11, and the 9 megahertz transducers. For Shearwave, again, the technique is exactly the same. You light touch, hold the transducer still, position the patient the same way, take a short cine clip, and do your measurements. And again, you can just push the buttons, keep your probe in the same place, and just push strain and shear wave, and you can do both without moving the transducer. It can be performed in all the transducers, but remember that the higher the frequency of the RF pulse, the more it's going to get attenuated. So if you have a very dense breast or big breast, you may run out of energy in the higher frequency transducers. The 9 should be able to work on all patients. Again, hypoechoic irregular mass, some color flow. The E to B ratio is going to end up being greater than 1, and I have it blocked here so I can't see it, is 1.5, so we suggest this is going to cancer. And again, you'll notice that same appearance. The cancer is black, everything else is white. On Shearwave, again, the cancer itself is blue, but we do have that little red ring around it. Oh, there's some red. And then we can use what's called the shell function. So here we put the original ROI just in the lesion, and then the shell is this other one that we can control the size, and that includes that little red dot. And when we look at the shell, that's 75, so it's above 60. So even though the cancer itself is very soft, having that ring tells us that this is a cancer, and on strain it told us it was a cancer. Again, let's look at the cyst, Bullseye Artifact, low signal on Shearwave. And again, here's one problem with a very dense breast. And here you can see with the 9, we can penetrate it and get good measurements. And what happens when we go to the 14, we kind of run out of energy because this lesion is so stiff. And on our quality map, again, you can see that this part is green, this part is purple, telling us it's low quality. And that's where we ran out of energy, and we're not generating shear waves. So just be aware of that, and this doesn't happen very often, but if you do have a very large breast, that can be a problem. And again, you have this cell feature where you can do 2 rings. You can put the small ring on the cancer itself to get a measurement, and then you can adjust the size of the ring to include that surrounding tissue if you want to get measurements in both locations. So what are the cutoff values for the Resonance 7? For strain, I use the E to B distance ratio. Less than 1 is benign. Equal to or greater than 1 is malignant. And I use 1 also, we biopsy, because we've had some mucinous and colloid cancers that had a ratio of 1. So we do a biopsy on 1. It does decrease our specificity, but it makes our sensitivity extremely high. And I will tell you that mucinous cancers and colloid cancers will not give you the Bullseye Artifact because that material is not moving. It's too thick inside to do that. You can use the 5-point color scale. Most people use the 1 to 3 as benign and 4 and 5 as malignant. And the strain ratio, again, I like to use 4.5, but you must use fat as the reference. And for shear wave, I use 4.5 meters per second or 60 kilopascals. I will tell you that a lot of people like to use 3.5 meters per second to make sure that they don't miss a cancer, but I'll talk to you about how I combine strain and shear wave to help avoid that. So how can we use elastography? So is a lesion benign or malignant? We can do the length ratio, the stiffness ratio, or the 5-point color scale. But also we can say, is the lesion soft or hard? Is it a fat lobule? It'll be very soft. If we feel a lesion and we don't see it on B mode, it may be an isoechoic lesion, and we may see it on elastography. So whenever you have a palpable lesion and you can't see anything on B mode, always turn on elastography. You may be amazed at what you find. We're finding now, particularly that we have the Bullseye Artifact, there are a lot of isoechoic complicated cysts. And I think it's important to know where to do a biopsy. So even if you've got a BI-RADS 4B, 4C, or 5 lesion, we do elastography because every once in a while we find out on elastography that what we think is one lesion is two, with one benign and one malignant, and knowing where the stiffest area is to do our biopsy is going to give you the better correlation with pathology. And as we're getting better and better, we're learning things how to characterize the structure of a lesion. So here we've kind of got a complex cystic lesion. There is some blood flow in that. You'll notice again on strain imaging, the lesion is much larger. I didn't measure the ratio, but it's obviously greater than 1. And again, here is the areas of this cancer are very soft, but we have this very stiff rim, which has a mean value of 162 and actually a maximum value of 472. So again, suggestive of a cancer. So strain and shear wave are suggestive of a cancer. This is the case I learned the most from. Looks like one lesion on mammography. We brought it to ultrasound to biopsy it. Here is the lesion. I like to say it had a head, a body, and a tail. And the tail I'm pointing with the green arrow, the red is the head. When we do our strain elastography, the head went away. The body and the tail got larger. We biopsied this lesion. It was an invasive ductal cancer. She had her lumpectomy. I asked the pathologist to pull out the slides from the surgery. It turns out that the head was actually a fibroadenoma. So if I would have just biopsied up here, I would have gotten a benign fibroadenoma and missed the cancer. And we've now had several cases like this where there are 2 lesions. We think they're 1. So I think doing elastography is very helpful for us to make sure we biopsy in the right location. I show this slide for 2 reasons. This is a mucinous cancer. It does have a ratio of 1. But again, you see the lesion extremely well on strain elastography. Why? The acoustic properties are the same as the background, so we don't see it very well on B mode, but the mechanical properties are extremely different. So we see it very well on elastography. The reverse is also true. Some lesions, like fibroadenomas and fibrocystic disease, show up as being very hypoechoic on B mode imaging, but their stiffness value is the same as glandular tissue. So if these hypoechoic lesions are in glandular tissue, when you do your elastography, you don't see them on strain because they just blend in with the background tissue. And we'll talk about that a little bit more. We published this paper several years ago where we looked at several hundred cancers that we did, and we looked at what was the E to B ratio. And again, the mucinous cancers tended to have a much lower value, DCIS a low value, and then as the grade of the cancers got higher, that ratio got higher. And you'll notice we had some that actually increased in size 3 times what they were on B mode. So just be aware of that and don't be surprised if you see that. Again, when I look at the multi-center trial, this is one of my cases that I messed up. I looked at this lobular hypoechoic lesion surrounded in red dots and said, wow, it got much bigger. It got as big as these green dots. We biopsied and it was fibrocystic change. And the reason is this is glandular tissue. And the stiffness value of the lesion is the same as glandular tissue, so it just blends in. So I have now become smarter. And again, it's always good to learn from your mistakes. Hypoechoic lesion surrounded by glandular tissue. Hypoechoic lesion surrounded by glandular tissue. Here, I don't see the lesion. It blends in with all the background glandular tissue. It's going to be benign. In this case, the lesion is much larger and very stiff. The glandular tissue is a light gray and fat is white. It's very obvious that this is going to be a cancer. So again, this is very helpful. And now this may have been a cancer, that would have been a blue cancer on Shearwave, okay? So doing strain and Shearwave is helpful because in this case, it's not aesthetically pleasing to say, oh, I think it's going to be benign because it's the same as glandular tissue. Shearwave would answer the question because we could measure it exactly on the lesion and they'd both be soft. In this case, this may have been a blue cancer and we may have had a false negative, but on strain, it's positive, so we would know. So the problems of strain are solved with Shearwave and the problems with Shearwave are solved with strain. Just another example, hypoechoic lesion, a little heterogeneous, it's still relatively well circumscribed. It has some blood flow. Here the ratio is almost 1. And again, here on elastography, the highest value is about, the mean is about 40. So we would consider that benign, and that turned out to be a benign fibroadenoma. But notice that the ratio here was 0.9 something. So that ratio of near 1 sometimes, and again, I like to biopsy them if it's greater than 1, so we don't miss cancers, but some of benign lesions, so we're always going to have a lower specificity. So how do I incorporate strain and Shearwave into our practice? So if both strain and Shearwave are suggestive of a benign lesion, I have very high confidence the lesion is benign. The only false negative that I have is lymphoma. All of ours have been well circumscribed, very hypoechoic lesions with marked internal blood flow. So if I see those characteristics, particularly in a patient that has lymphoma, we would biopsy the lesion even though both strain and Shearwave are benign. I will tell you that half of the breast lymphomas we diagnosed did not have a diagnosis of lymphoma. So it's very important to recognize that appearance on biopsy regardless of the elastography. If both strain and Shearwave are suggestive of malignant lesion, we have very high confidence the lesion is malignant. Our false positives are mastitis, fat necrosis, a few less than 5% fibroadenomas, and I would add radial scars or sclerosing lesions. Why? Because particularly for mastitis and fat necrosis, if it's acute, we have associated edema. So for those of you that do liver elastography, know that if you've got acute hepatitis, the liver becomes stiffer because of the inflammation. Same thing happens in the breast. So we see that inflammation as giving increased stiffness around the lesion. We don't see it well on B mode. So the lesions appear to be larger on strain and they're much stiffer on Shearwave. So if we think that the patient has mastitis, instead of biopsying, we would treat and do a short-term interval follow-up. If the mammogram is calcification suggestive of fat necrosis, again, we would consider a short-term follow-up. If strain is positive and Shearwave is negative, check the quality of the measurement of the Shearwave. If the quality is poor, that's probably going to be a malignant lesion. And in general, all these lesions are going to be malignant, and we biopsy them. And if they're BI-RADS 4B, 4C, or 5, we're certainly going to biopsy them. If the strain is negative and the Shearwave is positive, which I must say I rarely, if ever, see, check to make sure you didn't add pressure, precompression, when you're doing the Shearwave. You can also check the stiffness value of fat. It should be about 1.2 or 1.3 meters per second. If it's much higher, repeat your measurement with less pressure on the breast. If it's still positive and suggestive of a malignant lesion, obviously we would do a biopsy. So both strain and Shearwave provide additional information on breast lesion characterization. Technique is critical, always done in conjunction with B mode. Strain, at least in our hands, has the highest sensitivity, and Shearwave has the highest specificity. There's a significant improvement in the sensitivity of Shearwave with the addition of the quality measure or quality map, and the combination of strain and Shearwave may increase confidence and accuracy. So with that, I'm going to end, and I hope that I provided you with some information on breast elastography, and I can convince you to use it, practice, practice, practice. It's unfortunate that I can't be there to help show you some hands-on cases, which I think is very helpful. Hopefully in the next year I'll be able to come and see you in India and perform some cases live. Thank you again, and I want to thank Mindray for inviting me to give this talk. Thank you.